So we've just covered two very extensive lectures on what interventions are required when we are dealing with critical patients. However, as intensivists, we also want to give holistic care, and therefore we need to address the needs and stressors that the patients and the family members experience when they get admitted into ICU. So to answer that question as to what that may be, I'm looking into a journal that publication that was published in 2023 June about a study done in a tertiary hospital in Malaysia, which looked at the needs and experiences of critically ill patients and their family members. So just wanted to highlight how qualitative research is different from quantitative research because it's a very upcoming research that's available in a lot of publications. Unlike quantitative research, which looks to identify an absolute truth or where you're looking to prove a hypothesis, qualitative research actually looks to go in depth into the perceptions, into the beliefs or the opinions of the context that you're looking at. So it actually is used to generate hypotheses rather than to prove hypotheses. It's also a very flexible field where you alter your protocol based on the opinions or the results that you're getting while conducting the studies. And the researcher is as important an instrument in the study as is the protocol that you have or the questionnaire that you have, because the researcher's biases, the researcher's interaction with the patient or the participants also influences the outcome and the results that are published as much as the data that you generate. So unlike quantitative study where the sample size is large to be able to identify your hypothesis or whether it's correct or not, qualitative studies deal with a smaller sample size because you want to go into in-depth knowledge about what the situation that you're looking into is. Sorry. The quantitative studies are also very objective, whereas the qualitative studies are more subjective in nature. And it uses something called as thematic or a content analysis, which is an inductive way of looking into the data that's generated to come up with the themes that are being generated through the study. So coming back to how you would appraise a qualitative study using the CASP questionnaire, you look at three things: whether the study was done in a valid way, what were the results of the study, and then whether you can use the study in your population. So coming to whether this study that we are appraising was valid, I am just highlighting the questionnaire. So how you approach a questionnaire is there's a question, and then the CASP questionnaire gives you hints as to what questions you can look at to answer the question. So this study looked at a very focused question as to learn about the needs and experiences of critically ill patients and their family members in the local setting. And it was considered a relevant study because understanding these needs will help address those needs and therefore therefore alleviate the stress that patients and family members go through during their admission to ICU. So was the qualitative methodology appropriate for this study? I would say yes, because certain nuances and details about the beliefs, the perceptions, and the opinions of patients and their caregivers may not be highlighted by a quantitative study, and therefore qualitative methods seemed appropriate for the same. Then what are the research designs used for the study and was it appropriate? So when you look at qualitative research, there are multiple designs that you can use to generate the data. You can use in-depth interviews, you can use focus group discussions, or you can use case study research as well. In this study, they have used in-depth semi-structured interviews. They've not explicitly mentioned why they've chosen this, but it seemed appropriate. One thing that I thought was they could also have included a quantitative aspect to the study using multiple scoring methods that are available to add as an adjunct to the study. So was the recruitment strategy adequate? So what they have used is they have recruited both patients and family members. Patients who were 18 or above, who were admitted to the ICU for the first time and had at least 72 hours in the ICU to form their opinions, were included in the study. They should have been able to speak the local language, and the mentation should have been adequate as assessed by the GCS RAS and ICU CAM scale. When it came to family members, they recruited family members who were directly talking to the critical care personnel and who were willing to share their experiences. They've excluded relatives whose patients were critically ill out of respect of that, but I thought that could have reduced maybe some negative opinions that could have emerged during the study. How they identified these patients was they identified these patients during ward rounds and then later asked them for consent if applicable. they've used purposive sampling. So the purposive sampling is used to increase the heterogeneity that you get in your data so that you get wide variety of opinions. So they have tried to use it based on age, gender, the relationship with the patient, and what unit the patient was admitted under to include various opinions that could have emerged. This is the characteristics of the participants that were included in the study. And the median age of the patients included were around 42, and the family members was around 62. Now, coming to, was the setting adequate? So they chose the patients and interviewed them bedside, ensuring that adequate privacy was maintained. And the relatives were interviewed in nursing office in the ICU itself. They've used semi-structured in-depth interviews. So these semi-structured in-depth interviews actually are based on interview guides, which are generated by literature review. And then they use those literature guides to actually moderate in-depth interviews with the patients. These trial interviews were done with these interview guides to ensure that the interview guide that was generated was adequate. They have not mentioned about any changes in the methodology or any adaptation, but because qualitative study intrinsically is a flexible design, I'm assuming that there would have been adaptations on the way of the study. One thing that I thought was not appropriate in the study was that they have limited the data to 6 interviews. They have said that by the time the 6th interview was done, COVID restrictions were in place, and therefore they had to stop the study. But they had achieved their data saturation. So unlike quantitative studies where sample size is calculated based on prevalence and through a formula, qualitative study sample size is based on whether you reach data saturation, which means there are no new emerging themes coming up by the time you're interviewing your last or penultimate patients. Based on literature review, most of these studies, you will at least require 8 to 10 interviews to reach data saturation. However, here they have stopped at 6. So that is something we may have to keep in mind while interpreting the results. Then the next thing that you look at is whether the researcher and participants' relationship has been commented on. Here, the interviewers were 2 postgraduates from medicine and pharmacy, and they have not been interacting with the patients before, and therefore had no prior relationship with them. However, they have not mentioned how the researchers' own ideas and beliefs have biased the result, which they should have mentioned. And how have ethical considerations been taken into the study? So they have obtained written consent and they have gotten ethical permission from the research board. However, they have not mentioned how the confidentiality of the interviews that were collected was taken into account. So coming to that, apart from the fact that the sample size may not have been adequate, I thought it was a well done study, and I would want to look at the results. So how they've analyzed or how they've analyzed the results, they've used a 6-step thematic analysis, which I'll come to. And based on the thematic analysis, they have generated themes and then sub-themes under the themes to see what are the emerging topics or concerns that came out of the study. So this is the 6-step thematic analysis where one familiarizes themselves with the data that's generated initially, then it generates initial codes, then looks at themes and reviews those themes. Then they name those themes and then produce the report at the end of it, which the researchers have gone through in detail. Is there a clear statement of findings? So they have explained the findings very clearly. There was enough discussion about for and against the arguments that were put forward. 2 analysts had separately coded the interviews, increasing the data validation. However, one thing that they could have done was respondent validation. That's when they transcribe the interviews, whether what they generate is what the initial responders wanted to say. They could have done that as well, which was not done. So coming to the results now, the themes that were generated were divided into 3 themes: critical care services, physical spaces, and monitoring technology. Under each, they have various sub-themes and sub-themes, which I'll come to. So when it came to critical care services, they had 4 sub-themes: medical, physical, social, and psychological. Medical needs, they have talked about 5 sub-themes under it. So one was continuous pain relief management, where certain patients have reported that pain management was not adequate and they would like better pain management. A lot of patients and relatives mentioned about effective communication in terms of having having one single nodal person to contact daily and having regular updates about the patient. They also mentioned about some cultural competence care based on patients' beliefs, religions, languages. Care could be altered based on that. Certain family care, relatives expressed wish to participate in patient care because they thought it will help them cope with the stress. So small procedures like suctioning or giving chest physiotherapy, they said they could volunteer for the same. At the end, decision making was left to the ICU personnel because most patients and caregivers felt that they did not have enough medical background to make decisions. I just want to highlight how reporting is done in a qualitative study where quotes are published, which supports the themes that are generated, and you also attribute to which of the participant has mentioned that quote. Coming to the psychological needs, many patients and relatives asked for ICU personal care support, religious support, and counseling services. Physical needs, some patients said they wanted warm water baths, which was not available, and that could hamper their getting better. And a lot of patients and relatives wanted longer visiting hours. Coming to the second theme, which was physical spaces, there was both medical and non-clinical spaces. When it came to clinical spaces, most patients perceived that the environment was very cold and they would want extra blankets. Non-clinical spaces, most relatives felt that the waiting space was not adequate and they would want more chairs. Coming to monitoring technology, most of them had good opinion about it, and they said the ICUs were well equipped. However, the patients were often distressed with the alarms that were going off all the time, and it made them very apprehensive. And some family members complained that the call bells that are next to isolated patients may be malfunctioning, which could be looked into. So will the results help locally? I thought the investigation was done fairly well, and it addressed various ways in which ICU setups could be changed to address these concerns that patients and their family members have. So coming back to our scenario, some of the things which could be implemented is one is concentrating on optimal pain management, effective communication being a very good stronghold for patients and family relatives to feel good about the treatment being given. Encouraging participation of family care relatives in patient care in whatever ways is possible. Trying to arrange flexible visiting hours and better waiting area facilities, and to see if we can have judicious alarm systems and quiet times in ICU, especially at night, to ensure that patients are not very inconvenienced by the alarm systems. So additional resources that one can look at to understand qualitative research better or publish it is correct checklist, SRQR checklist, or equatornetwork.org. Thank you.
Okay, thanks, Sakshi. We'll quickly run to a few questions because of the lack of